Hello, dear future nursing officers. Welcome you all to the Master Nursing classes. Hope everyone joined to the session and fatapat do share the class to the available groups in your WhatsApp and put the class to your WhatsApp status as well. And who all are live to the session, so fatapat hit the like button. And if you know, if anyone of you are new to the Master Nursing classes, please do subscribe to the channel. So it is a channel which is giving the lots of the information in the short period of the time without wasting a single minute of the aspirants, right? So welcome once again every one of you to the Master Nursing classes. A very good evening beta, good evening, very good evening to every one of you. So fatapat do share the class to your friends and we will start the today's session with this particular and very important beautiful motivational line. Beta, if you want to achieve something in your life, means you have to dream it first. Then you have to believe in your dream and you have to build it. So how you have to build it? You have to build it with a discipline, you have to build it with a consistency, and you have to build it with a mindset of the champion. So then only the victory will be yours, right? So just dream it, believe in you. Okay, everything is possible, nothing is impossible. If you are believing in yourself, yes, you can do anything. You can do anything, you have that power. So just try to believe in yourself. So that is makes a difference from the depressed person and the champion person. Okay, if you are believing in you, so yes, you are the champion person. If you are not believing in you, if you are like you are a depressed person. Okay, so don't put yourself in the negative thoughts, be in positive vibes. Okay, create a positive vibes around you so that it may help others also, right? Yes, very good evening every one of you, and hope many of you have already joined. And I will start this particular very important session with this small information to every one of you here. So the information is, we have the Super 60 test series in our Master Nursing classes app, which is giving the real-time practice to the aspirants who are preparing for the Norcet exams. Okay, and yes, especially who all wants to achieve the aims Madurai. This particular test series is very much helpful to every one of you, because here we are giving the practice based questions, MCQs from the NCLEX, and the practical based, scenario based, priority based, and one liners, the most important image based questions, including the every nursing subject, including the non-nursing subject, as a real-time exam. That is the 20 multiple choice question for the 18 minutes, 5 section, total 100 MCQs for the 5 section. Okay, and as you are getting the same scenario in the Norcet prelims, similarly we are giving the same scenario in your test series also. Okay, so if you want to become a part of this one, so please join to the Master Nursing classes app. I have given the link in the description box. Okay, so the particular Super 60 live test will be live from the 6 a.m. to the 11 p.m. and you will get the All India rank at the 11:30 p.m. same day. Okay, and there are the free tests also available at every Sunday. At the All India level competition, you can assess yourself. Okay, and most importantly, we will announce the result in our Telegram group and WhatsApp group. And if you are not a part of that one, I have given the link to join that one. Okay, you can join to particular groups at the end of the class. Okay, so with this very informative words, we will start the today's session. And here will be a first question coming in front of you all. What is the correct definition of the pregnancy induced hypertension? Okay, or what we can say that one as the PIH. Okay, so what is the correct definition of the pregnancy induced hypertension beta? So option A is in front of you all like this: a blood pressure of the more than 180 by 90 mm of Hg before 20 week of the gestation. Is that correct answer? No beta. To say this is the pregnancy induced hypertension, the BP is 140 by 140 by 90. Okay, so after the 20 week of the gestation is the correct answer. Okay, so option A goes to the wrong. Okay, so here's the next option B: a blood pressure of the more than 140 by 90 mm of Hg after the 20 weeks. Okay, so without proteinuria. So this goes to the a standard definition of the pregnancy induced hypertension. Okay, and option C comes to the blood pressure more than 160 by 110 mm of Hg with proteinuria. Okay, so 160 by 110 mm of Hg with proteinuria after 20 week of the gestation. So this is a case of severe preeclampsia. Okay, this is a case of severe preeclampsia. And here the blood pressure more than 140 by 90 mm of Hg after 28 week, after 20 week of the gestation without proteinuria. So this is the standard definition of the pregnancy induced hypertension. Okay, so let me discuss a very important points on the pregnancy induced hypertension. Yes, what is the criteria? What is the criteria? Criteria is very simple, better. So in the pregnancy induced hypertension, before the pregnancy mother is absolutely normal. Okay, before the pregnancy mother is absolutely normal. Okay, so at the 20 week of the pregnancy, at the 20 week of the pregnancy, due to the problem in placenta, due to the problem in placenta. Okay, so now there is more than 140 by 90 mm of Hg blood pressure is there. Okay, this one I have checked two times on two occasion. Okay, so on two separate occasion. Okay, with 4 hours gap, with 4 hours gap. So this is the diagnostic criteria of the pregnancy induced hypertension. Very, very important, keep in your mind. So after the 20 weeks, after 20 weeks, due to the problem in the placenta, the blood pressure is going more than 140 by 90 mm Hg. Two times I have checked, and with 4 hour gap I have checked. So still the blood pressure is more than 140 by 90 mm Hg. So this is the criteria of the pregnancy induced hypertension. Okay, so here no proteinuria, here no protein urea. Very, very important, keep in our mind. In the PIH no proteinuria, but in the preeclampsia there is proteinuria is there. Okay, so there are the two situations in the pregnancy. Okay, so there are two situations are there. Consider there are two situations. One situation is the, yes, already a hypertensive. Okay, already hypertension present. So this lady or the this mother, she become pregnant now. Okay, so she become pregnant now. Okay, hypertensive lady conceived now. So this is what we call as in the chronic hypertension in pregnancy. What we call this one is in the chronic hypertension in pregnancy. Very, very important, keep in your mind, beta. So the first situation is already a lady or the a woman is having the hypertension, now she become pregnant. So this one I call as in the chronic hypertension in pregnancy. Okay, so one more thing, that is the a normal woman. Okay, so normal lady, she don't have any hypertension before the pregnancy. Okay, so at 20 week, at 20 week, due to the problem in the placenta, due to the problem in placenta, so her blood pressure is coming more than 140 by 90 mm of Hg. Okay, so there is high BP, there is high blood pressure. So this one I will call as in the pregnancy induced hypertension. Okay, so this one I will call this one as in the, just give me a second. So this one I will call as in the pregnancy induced hypertension. Very, very important, keep in your mind. Okay, so in the pregnancy induced hypertension, in the pregnancy induced hypertension, so again you will get a very, very important thing. So there's the PIH or the hypertension in pregnancy. Okay, so that is the hypertension in pregnancy, or we can say just a pregnancy induced hypertension. Okay, so in this particular situation, blood pressure is more than 140 by 90 mm of Hg, and I told which is two occasion, 4 hours gap. Okay, but no proteinuria, no proteinuria. Okay, but in case of the preeclampsia, in case of the preeclampsia, so the BP, the blood pressure will be more than 140 by 90 mm of Hg, and present of proteinuria. Very important. Keep in your mind. Okay. So proteinuria is present means that is the preeclampsia, and high BP in pregnancy but no proteinuria. That is the pregnancy-induced hypertension. Yes. So what is the pregnancy-induced hypertension? Pregnancy-induced hypertension is the high blood pressure more than 140 by 90 mm of Hg and no proteinuria. So this is the pregnancy-induced hypertension. What is the preeclampsia? So blood pressure more than 140 by 90 mm of Hg and there is present of the proteinuria. So this is the preeclampsia. Okay, but preeclampsia again we will divide into the two types. Again we will divide the preeclampsia into the two types. Okay, so remember. So this preeclampsia is again divided into the two types. One is mild preeclampsia, another one is severe preeclampsia. Okay, so what is first one? First one is the mild preeclampsia. Okay, so another one is severe preeclampsia. Another one is severe form of the preeclampsia. Okay, so remember in the mild preeclampsia what happens? In the mild preeclampsia what happening here? So BP so blood pressure is going more than 140 by 90 but it is less than 160 by 110, and here in the severe preeclampsia BP is going more than 160 by 110 mm Hg. Okay, so proteinuria present in both. Okay, in the mild preeclampsia also proteinuria is there, and in the severe preeclampsia also proteinuria is there. But one more very important differentiating term, in the severe preeclampsia there is sign of end organ damage present, but in the mild preeclampsia there is sign of end organ damage is absent. Okay, so very important, keep in your mind. So mild preeclampsia BP is more than 140 by 90 and less than 160 by 110, but sign of end organ damage is absent. In the severe preeclampsia BP is more than 160 by 110 plus sign of end organ damage is there, and proteinuria will be present in the both mild and severe preeclampsia, but proteinuria is absent in the pregnancy induced hypertension, and in the preeclampsia proteinuria is present. Okay, so very important, these all the definition is much necessary for you all. Okay, so what is the preeclampsia? Preeclampsia is the high blood pressure with proteinuria in the pregnancy is the preeclampsia. Okay, in the preeclampsia two types, mild preeclampsia, severe preeclampsia. In the mild preeclampsia BP is more than 140 by 90 but less than 160 by 110 mm of Hg. Proteinuria will be there but there is no sign of the end organ damage. Okay, in the severe preeclampsia BP is more than 160 by 110 mm of Hg and proteinuria will be there. Along with that, the sign of the end organ damage also will be there in the severe preeclampsia. Okay, so very important one, keep in your mind. And the pregnancy induced hypertension. So here the PIH, the BP is more than 140 by 90, but there is no proteinuria. But in the preeclampsia, I told the BP is more than 140 by 90, so proteinuria is also present here. Okay, so the proteinuria is present here. Very important thing I have taught to you people. And the two situations, one is hypertension in the chronic hypertension in pregnancy, means already a lady is hypertensive, now she become the pregnant, so that is called as the chronic hypertension in pregnancy. And the normal lady, okay, so before the pregnancy there is normal blood pressure, after the pregnancy at the 20 week of the due to the problem of the placenta there is high blood pressure, so such lady we call as the lady with the pregnancy induced hypertension. Okay, so very important, here the definition was asked is related to the pregnancy induced hypertension. Okay, so now choose your correct answer. So that is the high blood pressure, right, more than 140 by 90 mm of Hg. Yes, after the 20 week, yes, it's after the 20 week. Okay, so without proteinuria, if it's proteinuria we call this one as in the, yes, we call this one as in the a case of preeclampsia, beta. Yes. So option C, blood pressure 160 by 110 mm of Hg. So I told in the severe preeclampsia, it's more than 160 by 110 mm of Hg. With proteinuria, yes, it is also after the 20 week. Okay, along with this, here and there, sign of the end organ damage also you will get in the severe preeclampsia. Okay, so in the severe preeclampsia, very very important, keep in our mind. Okay, so hope the definition are very clear to every one of you, right? So the next one is here. Yes, Padafat, do read the question and response to the question in the comment box. I'm waiting for your answer. Which of the following is a sign of end organ damage in the preeclampsia except one? So I told here in the pregnancy induced in the preeclampsia, I told there are the two types of the preeclampsia. One is mild preeclampsia, right? Just now only I told, and another one is the severe preeclampsia. Okay, so in the mild preeclampsia, BP is more than 140/90, but less than 160/110, and proteinuria present. Okay, but there is no sign of end organ damage. Okay, there is no sign of end organ damage. So in the severe preeclampsia, what I told, the blood pressure is going more than 160/110, and proteinuria is present, and sign of end organ damage is present. Okay, so this is the very very important thing. Just I have explained just in the last question only. Okay, so here we discussed the sign of end organ damage is present. Okay, so what are the sign of the end organ damage? Sir, how to remember that one? Remember like this. But sign of the end organ damage is very simple. Just draw the head. Okay, so in the head, so you have to say that there is a cerebral edema. Okay, in the head, what happening? There is a cerebral edema. So due to the cerebral edema, the vision. Okay, so there is a visual disturbance also will be there. Okay, so cerebral edema, then comes to the visual disturbance. Okay, so then comes to the close of the head, and now our chest starts, that is the lung starts. Okay, so that is our lung starts. Okay, so here in the lungs we will get the pulmonary edema. Okay, so we will get the pulmonary edema. Okay, so then after the lungs, what starts? The liver starts, right? So here the liver enzymes, liver damage happens, and here the liver enzymes become double. Okay, so here the liver enzymes more than 2 times, more than 2 times, so liver enzyme becomes double. Okay, so then comes to the very very important damage to the kidney. Okay, so damage to the kidney, urine output decreases. Okay, so very very important, just keep in your mind, cerebral edema will be there, visual disturbance will be there, pulmonary edema will be there, liver enzyme becomes double, and the very very important, our like urine output decreases. Along with that, the platelet counts become low. Okay, so platelet count becomes low, thrombocytopenia we will get. So these all are the sign of end organ damage. Yes, quickly revise. Sign of the end organ damage: cerebral edema, visual disturbances, pulmonary edema, liver enzyme doubles, and the kidney damages. Kidney damage means urine output decreases, and the creatinine level. The creatinine level. Okay, so you can write here as a best. That is the decreased urine output also you can write, or the creatinine level becomes more than 1.1. Okay, so this is also a standard criteria. Okay, and platelet becomes very much low here. Okay, so these are the sign of the end organ damage. Beta, remember, very very important, and one question there may be asking in your exam. Okay, so these are the sign of end organ damage. Okay, so keep in your mind, right? So comes to the multiple choice question. Where is our question here? Here it is the question. So which of the following is sign of the end organ damage? Okay, in the preeclampsia except one. Okay, so in the where we will get the sign of the end organ damage, we will get this one in the severe preeclampsia, right? In case of the severe preeclampsia, we will get, okay. So option A, serum creatinine level is more than 1.1. Yes, I told in the kidney. Yes, first one is the cerebral edema, visible disturbances, pulmonary edema, and liver enzyme becomes double, then the kidney comes to the down, from up to down, okay. In the kidney damages and the serum creatinine become more than 1.1 mg per deciliter, okay. So this is the sign of end organ damage, but in the question they have asked except one, okay. So one is not a sign of the end organ damage here, okay. So option B is the visual disturbance. Yes, I told cerebral edema. Second one is the visual disturbances, then the pulmonary edema, okay. So this is the pulmonary edema is also sign of end organ damage, and the increased platelet level is not a sign of end organ damage. This one is a, okay. So here in the sign of the end organ level, we will get the low platelet, okay. So low platelet level, so that is less than 1 lakh, okay. So we will get the platelet level here is the less than 1 lakh, okay. So very important thing, keep in your mind. So option D goes to the correct answer for this particular question, because in the question they have asked the except as the correct answer, okay. So hope it is clear to every one of you. And here is the next question. Yes, question is waiting for every one of you. Fatapat to response to the question. Yes, which of the following is a common sign of impending eclampsia in a woman with preeclampsia, okay. So remember beta, whenever the patient will comes with a severe preeclampsia, okay, so anytime patient may throw the seizure, okay, anytime patient may start seizure, or anytime he starts convulsion, okay. So if severe preeclampsia plus seizure both is happening, means we call this one as in the case of eclampsia. What we call this one? So this is the case of eclampsia. What is eclampsia? Eclampsia is a severe preeclampsia plus generalized or clonic tonic seizure. We call that one as in the eclampsia, okay. But before starting the seizure, or the before converting from the severe preeclampsia to the eclampsia, so there are the warning sign, okay. So there are the warning sign, we can say, or we can say this one is in the sign of impending eclampsia. Also we call this one as in the sign of impending eclampsia. So what are the sign of the impending eclampsia? Okay, again remember the same thing, head, okay. So in the head there is headache is there, which is not relieved by, or the not relieved by normal treatment or the usual treatment, okay. So headache is there which is not subsiding by the usual treatment, okay. Usual treatment we are giving, so for that the headache is not subsiding. After that visual disturbance is there, okay. So again there is visual disturbance, okay. So along with that there is the epigastric pain will be there, okay. So now head, okay, eyes, then the face closes, then comes to the epigastric area. In the epigastric area we have the epigastric pain. Epigastric pain will be there, okay. So along with that to the kidney, urine output become less than 30 ml per hour, okay. So these all are the warning signs of the eclampsia before onset of the eclampsia, or before converting the severe preeclampsia to the eclampsia. So these are the warning signs or the sign of the impending eclampsia. If patient is complaining the headache that is not relieved by the usual treatment, and the visual disturbances, epigastric pain, and the urine output less than 30 ml per hour, so these all are the very important warning sign of the eclampsia, means the patient is about to throw the convulsion, or now the severe eclampsia, preeclampsia patient may about to start the convulsion, and now the patient may get converted into the case of the eclampsia. Okay, so these are the very important. And what is the nursing responsibility? As a nursing officer, you have to monitor all the sign of the impending eclampsia. If patient is telling headache is there, if patient is telling visual disturbance is there, if patient is telling epigastric disturbance and pain is there, and if patient is saying he is unable to wire the urine. Okay, so very important, these complaints especially the patient is giving means, so these are the warning sign of the eclampsia. Patient may anytime get converts from the severe preeclampsia to the eclampsia, so these are all called as the sign of the impending eclampsia. Very important, keep in your mind. Okay, so let's come to the question now here, right? Which of the following is the common sign of the impending eclampsia in a woman with severe preeclampsia, we can say, or the preeclampsia? Okay, so option A, mild ankle edema. It is not a sign of the impending eclampsia. So option B, sudden weight loss. No. Option C, persistent severe headache with visual disturbances. That's what I told. So there will be a head means there will be a headache and visual disturbances. Okay, along with visual disturbances. So very important one, epigastric pain. Along with the epigastric pain, okay, so low urine output. Okay, so kidney comes to the kidney. So in the kidney there will be a low urine output, right? So very important, headache which is not relieved by the usual medication, visual disturbances, okay, epigastric pain, and urine output less than 30 ml per hour. So these all are the warning sign or the sign of impending eclampsia. Very important, keep in your mind. Hope it is clear to everyone of you all. Okay, so the correct answer for this question goes to the option C. Okay, so how to remember also I have told the sign of impending eclampsia. So this will be very much useful to everyone of you all. Okay, so this is your very important question. Definitely this question will strike in your exam, and whatever the concept I am explaining behind this question will definitely strikes in your prelims also, in mains also. Yes sir, two questions will come sir. Yes sir, two questions will come from this one. Okay, so don't neglect. Okay, so try to give response to the question first, so then we will go to the in detailed discussion of this particular question. Okay, so yes, the question is, which of the following correctly describes the Pritchard regimen for magnesium sulfate administration in eclampsia? Yes, so there are the two total regimens are there. One is the Jupsin regimen. Okay, so another one is the Pritchard regimen. Okay, another one is the Pritchard regimen. So these two regimens are very important to administer the magnesium sulfate. Okay, so which one is the Pritchard regimen is here? Yes, option A, 4 gram IV lignocaine, IV loading dose followed by the 1 gram per hour IV infusion. So this is the Jupsin regimen. Option E is talking about the Jupsin regimen. Okay, here the 4 gram IV loading dose we will give followed by the 1 gram per hour IV infusion. Slowly with the infusion pump we will give. Okay, so only IV injection, there is no IM injection in the Jupsin regimen. Okay, so in the Pritchard regimen we will give both IV and IM. Okay, so option B is telling, okay, option A, this is the not Pritchard regimen, this is the Jupsin regimen. Okay, option B is the 10 gram IV loading dose followed by the 5 gram IM every 12 hours. No, this is not correct one. Okay, so option C is the 4 gram IV plus 10 gram IM loading dose followed by the 5 gram IM every 4 hourly. Okay, so this goes to the correct answer. Option C goes to the correct answer here. Okay, so then comes to the option D, 6 gram IV loading dose only. So this is not correct. So option D I am eliminating. Better. So remember, the Pritchard regimen we will give the IV also, IM also. But in the Jupsin regimen, only IV is there. Okay, only IV we will give. Okay, remember, in the Pritchard regimen, loading dose is 4 gram of the IV slow for 5 to 10 minutes. Okay, followed by the 10 gram of IM. Okay, 5 gram in each buttock with the lignocaine. Okay, with lignocaine. Why? Because the magnesium sulfate injection is the very dangerous injection. When we will inject in the buttock, it will do the very dangerous pain. Okay, so that is the reason we will mix the lignocaine before administering the intramuscular injection. Okay, so very important, loading dose in the Pritchard regimen is the 4 gram IV slowly. Okay, followed by the 10 gram IM. Okay, 5 gram in right buttock, 5 gram in the left buttock. Very important thing, keep in your mind. Okay, so next comes to the maintenance dose of the our Pritchard regimen. Okay, so maintenance dose, there is a 5 gram Intramuscular we will give every 4 hours, okay, in the alternative buttock, right? So this is the very important thing. Just try to remember the Pritchard regimen. So this question will directly strikes in your exam, okay? So I'm tracking related to the Pritchard regimen. So in the Pritchard regimen, remember loading dose. Remember the loading dose. In the loading dose, we will give 4 gram IV for the 5 to 10 minutes. Okay, slowly we will give, followed by 10 gram. Okay, intramuscular. Okay, that one 5 gram in right buttock, 5 gram, and in the left buttock 5 gram. Very important loading dose in the Pritchard regimen. Then comes to the maintenance dose. Maintenance dose we will give the intramuscular route. Okay, so that is the 5 gram every 4th hourly. Every 4th hourly. This is the Pritchard regimen to administer the MgSO4 magnesium sulfate in case of eclampsia. Okay, so very important, keep in your mind. Okay, so this is the Pritchard regimen. Okay, so remember duration of the therapy until we will give the magnesium sulfate till 24 hours after the last seizure or the 24 hours after the delivery of the baby. Okay, so till what duration we have to give? So till we will give continue for the 24 hours after the last seizure or continue after the 24 hours after the like delivery. Okay, so very important. If the seizure onset is happened now, okay, so I will continue next 24-hour MgSO4. I will continue, after that I will stop. Okay, or else if delivery happened now, so next 24 hours I will start the MgSO4. I will keep the MgSO4 on only. So after 24 hours I will make it off. Okay, so very important thing need to focus here. Okay, so very important thing, parameters need to monitor here. Okay, so remember the parameters you must and you should monitor before giving the our magnesium sulfate injection is the, okay, parameter to monitor. First parameter is before giving the MgSO4 you have to monitor the urine output. Okay, so urine output, if it is less than 30 ml per hour, don't give MgSO4. Sir, why sir? Why sir means this MgSO4, the magnesium sulfate, it will excrete through the kidney. Okay, if the kidney is damaged means the urine output will come less than 30 ml per hour. Yeah, urine output is less than 30 ml per hour means kidney is not functioning properly, means this MgSO4 will not excrete out of the body. So there will be increases the risk of the toxicity. So that is the reason. Okay, so if our urine output is less than 30 ml per hour, so don't give MgSO4. Very important. First, okay, first one parameter you have to monitor is the urine output. Okay, second parameter is the respiratory rate. Okay, so if it is more than 12, you can give. If it is more than 12 breaths per minute, okay, so you can give. If in case it is less than 12 breaths per minute, so don't give MgSO4 because it will causes the further respiratory depression. Very important. Then the third parameter you have to monitor here is the, so that is the very important parameter, that is the deep tendon reflex. Okay, so if the deep tendon reflex is present, then you have to give the MgSO4. If in case the deep tendon reflex is absent, so don't give MgSO4 because the absence of the deep tendon reflex is the earliest sign of the magnesium sulfate toxicity. Okay, so these three very important parameters we have to monitor here. Okay, so one is the respiratory rate. If it is more than 12 breaths per minute, so you can give. If it is less than 12, don't give. Okay, so then the deep tendon reflex, okay, if it is present you can give, if it is absent you don't give. And urine output, if it is more than 30 ml per hour, so you can give, otherwise you don't give the MgSO4. Okay, hope it is clear to every one of you, right? So then MgSO4 we are commonly using in the this particular Pritchard regimen. Pritchard regimen we are using in the where the PHC is there, where the subcenter is there. Okay, so not in subcenter, PHC, at least the community health center, where the infusion pump is not available and continuous monitoring is not available. In that situation, we will use the Pritchard regimen. Okay, if we are having the good setup of the hospital, okay, we are having the proper infusion pumps, everything is available, then we will go for the gypsum regimen. Okay, so in the gypsum regimen, only IV injection are given. Okay, in the Pritchard regimen, okay, loading dose also there is a IM injection. In the maintenance dose also there is a IM injection. Okay, 4 mg IV we will give. After that, a 10 gram, sorry, 4 gram IV we will give slow IV. Okay, after that the 10 gram in right, but like 5 gram in the right buttock, 5 gram in the left buttock in the loading dose only. Then after that, every 4 hourly 5 gram we will give as a maintenance dose. Okay, so in the Pritchard regimen, very importantly, we are giving the IM because we don't have the infusion pumps. Okay, so here are the low resource settings are there. Okay, without IV infusion pump, in that particular settings we can use the Pritchard regimen. Okay, so if you are having the high resource settings, okay, and infusion pumps, everything is available, and close monitoring, everything is available, so we can give the IV only. Okay, so that is the gypsum regimen where we will use. Okay, so that is the very important thing, keep in our mind. Then the advantage is, I told, this Pritchard regimen we can use in the low resource settings, so that is our good advantage. Okay, it doesn't require the infusion pump and doesn't require the close monitoring. Still, we need to monitor for the respiratory depression here. Okay, so the advantage of the gypsum regimen is the we can maintain the steady and constant serum level. Okay, and there is less chance of the like toxicity is there, and we are not pricking inside the muscle. Means I told the MgSO4 is the very dangerous injection where it may causes the muscle necrosis also sometimes. Okay, so in order to avoid the pain, we are mixing the lignocaine with the MgSO4 and we are giving the IM injection. Okay, but in the gypsum regimen there is no IM injection. Okay, so less painful, very important, right? So the disadvantage of this particular Pritchard regimen is it is very much painful at the injection site, and the risk of the injection site abscess and necrosis will be there in the gypsum Pritchard regimen. But in the gypsum regimen, it requires the infusion pump. This is the disadvantage, and it requires the costly equipments. So that is the disadvantage of the gypsum regimen. Very important, keep in our mind. And the loading dose we are giving the gypsum regimen is the 4 gram of the IV slowly for 5 to 10 minutes, and after that 1 to 2 gram per hour continuous IV infusion we will give. Okay, so this is the gypsum regimen, and the same duration of the therapy. Okay, last onset of the seizure, continue next 24 hours and stop. Last onset of the completion of the delivery to the next 24 hours you continue and stop. Okay, so this is the duration, and the same essentially we need to monitor for the respiratory rate and the deep tendon reflex and the urine output. Okay, respiratory rate more than 12 breaths per minute, give. If less than 12, don't give. Deep tendon reflex absent, don't give. Present, give. Okay, and the very importantly, urine output less than 30 ml per hour, don't give. More than 30 ml per hour, you have to give the very important MgSO4. Okay, so this is the more important question and the concept of what I have explained to every one of you here. Okay, so hope that Pritchard regimen and gypsum regimen is very much clear to you all. So this is your very important, I am telling, but keep in our mind. Okay, so the next question is here in front of you all, so do read the question and try to give the best answer. Which of the following best describes the component of the HELP syndrome? Yes, which of the following best describes the component of the HELP syndrome? Can anyone want to answer Fadafat in the comment box? Yes, comment box is open for you all. Fadafat, do response. Right. So what happens in the HELP syndrome? H stands there as the hemolysis. Okay. H stands here as the hemolysis. EL stands here as the elevated liver enzyme. Okay. What it stands here as the? It stands here as the elevated liver enzyme. And LP stands here as the low platelet. Okay. So we can say the thrombocytopenia also, this one. Yes. Examiner will give the thrombocytopenia. Why he will give the low platelet? He will give the cytopenia. Okay, so this one the examiner can give in the exam. Okay, so very very important, keep in your mind. Okay, H stands here as the hemolysis, EL stands here as the elevated liver enzyme, and LP stands here as the low platelet count. Okay, so that comes to the question and search for the option. Which of the following best describes the component of the HELP syndrome? Option A, hemorrhage. No, H stands as the hemolysis. It doesn't stand as hemorrhage. I'm eliminating the option A. Then comes to the option B, hemolysis. Yes, hemolysis will be there. Okay, and the elevated liver enzyme. EL is the elevated liver enzyme. Yes, and the low platelet. So option B best describes the HELP syndrome here, and the HELP syndrome is a complication of the. It is a complication of severe preeclampsia. Okay, so it is a complication of the severe preeclampsia, very very important, keep in your mind. Okay, so severe preeclampsia complications are HELP syndrome, and like there is a bleeding tendency due to the low platelet, and along with that there is a disseminated intravascular coagulopathy also we can happens, and along with that the very important one, that is the severe preeclampsia may get converted into the eclampsia. Okay, so there is the onset of the seizure, and severe preeclampsia plus seizure will be called as the eclampsia. Okay, so these are the some common complication of the our very very important like preeclampsia will be there. Okay, so hope it is clear to every one of you. And here is the next question: what is the definitive treatment for the management of the pregnancy induced hypertension and preeclampsia? So what is the definitive treatment? So I'm not asking the like temporary treatment, I am asking the definitive treatment of the pregnancy induced hypertension or the preeclampsia. What is the correct answer? Option A, antihypertensive medications. So this is the conservative management. Okay, so not definitive. MGSO4 administration. This is just to prevent the, okay, in the severe preeclampsia to prevent the seizure, and in the eclampsia to treat the seizure we can use the magnesium sulfate medication. Okay, and the option C is the bed rest and dietary modification. So bed rest and dietary modification is not definitive treatment. Okay, so it's not definitive treatment. The definitive treatment of the pregnancy induced hypertension and the preeclampsia is the delivery of the fetus and placenta. But many time I told the pregnancy induced hypertension is a problem of placenta. Okay, so it is the problem of the placenta, means a lady who is experiencing the pregnancy induced hypertension previously, before the pregnancy she is normal, and after the pregnancy she becomes normal. Okay, so now the definitive management is just try to deliver the placenta is out, and try to bring out the fetus out. Okay, so it doesn't mean to terminate the pregnancy. Okay, so just we will induce the labor here. Okay, based on the situation we will induce the labor here. Okay, so remember the definitive management of the pregnancy induced hypertension and preeclampsia is the, yes, that is the delivery of the placenta and fetus is the correct answer, because the PIH is a problem of the placenta, so treat the problem. Okay, so everything will be clear here. Okay, so very very important, remember the condition in the mild preeclampsia, severe preeclampsia, okay, and time of the delivery of the placenta and fetus. Okay, so remember in the mild preeclampsia we will wait till the 37 week of gestation we will wait, and after the 37 week of the gestation we will induce the labor and we will take out the baby out. Okay, in the severe preeclampsia, so till we will wait for the 34 week. Okay, so in the severe preeclampsia we will wait till the 34 week of the period of the gestation. After that we will terminate the placenta and fetus by induction of the labor. Okay, so then in case of the eclampsia, means severe preeclampsia is there, along with that seizures are also started, and HELP syndrome, which is the complication of the severe preeclampsia, and in the pregnancy induced hypertension with abruptio of placenta, and in the pregnancy induced hypertension with fetal distress. So these all situation you have to go for the immediate delivery of the baby. Okay, immediate delivery of baby. Okay, so this is the very very important thing, just you have to keep in your mind. Okay, so hope it is clear to every one of you, the time of the delivery of the placenta and definitive management of the pregnancy induced hypertension and preeclampsia. So that is the termination of the pregnancy or the like induction of the labor and take out the placenta out. Okay, that is the definitive management. Okay, hope it is clear to every one of you. And here the next question is waiting for you all. Yes, Which of the following is the preferred first line antihypertensive drug for the management of the pregnancy induced hypertension? Okay, so the drug of choice for the PIH is, yes, I'm waiting for your answer. Fatapat do answer in the comment box. Beta, what is the drug of choice? The first line preferred antihypertensive drug of managing the pregnancy induced hypertension or the PIH? Fatapat. Important question. Yes, the correct answer is many of you all are chosen the correct answer. That is the labetalol goes to the correct answer. Okay, so labetalol is the alpha plus beta blocker. So it is having the a very important role in the management of the pregnancy induced hypertension. Okay, so PIH, if someone is asking drug of choice, that is the labetalol. Okay, so that is the answer goes to the labetalol goes to the correct answer. Okay, so atenolol is just an beta blocker, so it is contraindicated. Only beta blockers are contraindicated in the pregnancy. If you want to give the beta blockers, it should act as alpha blocker also. Okay, alpha plus beta blocker labetalol we can use as a drug of choice in the pregnancy induced hypertension, but only beta blockers. Okay, like atenolol, it is contraindicated, and all the pills. Okay, like all the pills. These pills are the AC inhibitors. Okay, so these AC inhibitors all are contraindicated. Why? Why? Because so these AC inhibitors having the dangerous teratogenic effect that it will causes the renal agenesis. Okay, so there is no kidney in the fetus means yes, it will be causing the oligohydramnios, and it will cause the lung hypoplasia. Okay, underdeveloped lungs in the fetus. Okay, so lung hypoplasia. Okay, so these are the teratogenic effect of the pills. Okay, enalapril, captopril, all the pills are contraindicated. Okay, so nifedipine, nicardipine are the calcium channel blockers we can use, but these are not drug of choice. Okay, so nifedipine, calcium channel blockers are not contraindicated during the pregnancy. Beta blockers, only beta blockers are contraindicated. AC inhibitors are contraindicated, and that angiotensin receptor blockers, all the sartans. Okay, all the sartans like losartan. Okay, so some drugs comes as antihypertensive drugs, sartans. Okay, so some drugs called as the losartan, telmisartan, tablet telma, you have heard. Telmisartan is the full name. Okay, so telmisartan, these are the angiotensin receptor blockers. These are also contraindicated during the pregnancy. Okay, so keep in your mind. Okay, so very important. Just now drug of choice for the first line antihypertensives for the treating the pregnancy induced hypertension is the labetalol. Okay, so this labetalol is the drug of choice for the pregnancy induced hypertension, chronic hypertension in the pregnancy, and a very important in a situation called as the like hypertension crisis in the pregnancy, drug of choice is the labetalol. Okay, so second best drug is the hydralazine. I will teach that one also, don't worry. Okay, along with that in the preeclampsia also drug of choice is the labetalol. Okay, so very important, keep in your mind, right? So the next question is here in front of you all. Which of the following antihypertensive drug is not contraindicated in pregnancy? Yes, which is not contraindicated in pregnancy? Enalapril, I told, which is the ACE inhibitor. Okay, ACE inhibitor. So this will be a very dangerous drug. I told this will cause the renal agenesis. Okay, along with the renal agenesis, oligohydramnios, and the pulmonary hypoplasia. Just we have discussed. Okay, so enalaprils, all the pills are contraindicated. Okay, so all the pills, enalapril, captopril, ramipril. Okay, all the pills are contraindicated, and all the diuretics also contraindicated. All the diuretics also contraindicated in the pregnancy. Okay, so then the sartans, I told, all the angiotensin receptor blockers, sartans. Okay, so losartan, telmisartan are contraindicated. Methyl dopa. Okay, this is the vasodilator. Okay, so this is the blood vessel dilator, and a slow acting drug, and the slow acting drug, and the safest drug in the pregnancy. Safest drug in the pregnancy. That is our methyl dopa. Okay, so alpha methyl dopa is the safest drug in the pregnancy. Okay, so that is the reason we can give this one in the chronic hypertension in pregnancy, but the drug of choice is labetalol. Okay, and this is also best treatment we can give. Okay, so very very important, a methyl dopa is not contraindicated. Okay, so alpha plus beta blocker, labetalol is not contraindicated. Methyl dopa we can give, nifedipine. Okay, so there is the calcium channel blocker we can give, hydralazine we can give. Okay, so very very importantly keep in your mind. Okay, so this enalapril, diuretics, losartans are contraindicated during the pregnancy. Okay, so hope it is clear to every one of you, right? So here is the next question. Yes, which of the following drug is commonly used for rapid blood pressure control in a hypertensive crisis during the pregnancy? So, hypertensive crisis during the pregnancy. Okay, so option A methyl dopa, option B hydralazine, option C nifedipine, option D sodium nitroprusside. Okay, so these all drugs are used to treat the hypertension in pregnancy, but hypertensive crisis during the pregnancy, which drug is best? So the answer according to this option goes to the hydralazine. So actually this is the second best answer. So which one is the best answer, sir? So first best answer goes to the intravenous IV labetalol is the drug of choice for the hypertensive crisis during the pregnancy. So what is the dose? How much labetalol we can give, sir? We can give, sir. Yes, this is the dose criteria of the IV labetalol in the hypertensive crisis during the pregnancy. Remember, the first dose we can use the 20 mg. Okay, so after that we will wait for the 10 minutes. Then the second dose we will use the 40 mg. Then we will wait for the 10 minutes again. Then the third dose we will give is the 80 mg. Okay, so then again we will wait for 10 minutes. Okay, the fourth dose is the 80 mg. Okay, so after that we will check for the, we will switch. If it is controlling, that is good. Otherwise we will go for the hydralazine. Okay, so that is the reason a drug of choice and the first best drug in hypertensive crisis during the pregnancy is the labetalol. Okay, so total how much we will give? We will give it 220 mg. Okay, so labetalol maximum we can give. Okay, so this question have been asked in your exam. Okay, total maximum dose of the labetalol in the pregnancy in the hypertensive crisis during the pregnancy is the, so that is the very very important thing, that is labetalol is the first best drug. Okay, if this one is not there in the option, the hydralazine is the second best drug, and according to the option the correct answer goes to the hydralazine. Okay, so alpha methyl dopa, just only I told you. So this methyl dopa, it is in the slow acting drug. Okay, it is in the slow acting drug. Slow acting drug we are using in the hypertensive crisis means there is no use. Okay, so we can use this slow acting drug in the like chronic hypertension in the pregnancy, but we can't use that one in the hypertensive crisis, right? So nifedipine, it is on the also the slow acting drug. Okay, so nifedipine slow released one, so this is also slow acting, we can't use this one in the hypertensive crisis. Okay, sodium nitroprusside is the this one is the sodium nitroprusside. Okay, so this one is the drug of choice in refractory hypertension. In the refractory hypertension, what it means, sir? So refractory hypertension is mean very simple. We are giving the like hydralazine also, we are giving the labetalol also. Okay, so the blood pressure is not coming to the normal. So at that particular time, so to all the antihypertensive drugs, the hypertension is not controlling means, so that is what we call the refractory hypertension. In that particular situation, we will use the sodium nitroprusside. Okay, sodium nitroprusside is the drug of choice in the refractory hypertension. Okay, hope it is clear to every one of you, and correct answer for this question goes to the option B. So that is the hydralazine. Okay, because this is the second best answer for the hypertensive crisis in the pregnancy. The first best answer is the labetalol. Hope it is clear to every one of you. Yes. So the next question is here in front of you all. Okay, so what is the first step in the nursing management of a woman presenting with the eclamptic seizure? Okay, so what is eclampsia? Just now I told what is eclampsia. Eclampsia is the severe preeclampsia plus seizure. Okay, so in the severe preeclampsia, what it means? The blood pressure is more than 160 by 110 mm of Hg, and the proteinuria is present. Okay, and sign of end organ damage is present. So this is what we call the severe preeclampsia. Along with the severe preeclampsia, patient is manifesting with a seizure also. So I call this one as in the case of eclampsia. Okay, so what is this one? This is a case of eclampsia. Okay, so what happens in the eclampsia? In the eclampsia, a severe preeclampsia plus seizure will happen. So, okay, so this is the eclampsia. So seizure is happening means the first nursing management is always to manage the airway. Okay, so manage the airway, right? So how you will manage the airway in the seizure patient? Yes, so always give the left lateral position immediately. Okay, so that all the secretion which is coming out of the mouth, it will comes out. Okay, it will not aspirate also. Okay, so the first step in the nursing management of a woman presenting with eclamptic seizure is the, yes, give the left lateral position goes to the correct answer and the best answer, right? So immediately deliver the baby is not nursing management. Okay, yes, in the eclampsia, we will immediately deliver the baby, but we will make it arrange for the delivery, but we will only not deliver. Okay, so that is the very important. This is the immediately delivering the baby is the work of the obstetrician or the gynecologist. Okay, so it is not a work of the nursing officer. Just immediately first nursing management, what we have to do is to protect the airway by giving the left lateral position. Okay, then option B, administration of the intravenous magnesium sulfate. So this is after the order by the obstetrician. Okay, so not directly a patient is throwing the seizure and you loaded the eclampsia and you have injected. It's not like that. Okay, so then option C, administration of the antihypertensive drugs. So this is also not nursing management, and in the question they have asked post nursing management. So your answer goes to the option D, goes to the correct answer. That is the give left lateral position is the correct answer. Okay, so hope it is clear to every one of you, right? Yes, better in the eclampsia we will have the three types of the eclampsia. Remember, so among the three types, the most common one is the, yes, eclampsia will be divided into three types. Eclampsia is divided into three types. One is eclampsia during the pregnancy. Okay, so eclampsia during pregnancy, we call that one as the antenatal eclampsia. Okay, so this is a most common type and most worst. Okay, that is the eclampsia that happens during the pregnancy time. That is the eclampsia antenatal. Okay, so the second one is the internatal eclampsia, means eclampsia means seizures are happening during the labor. Okay, so during the labor, so it is the seizure happening during labor process. This is what we call as the internatal eclampsia. Okay, so one more thing, that is the postnatal eclampsia. So this is within 24 hours after delivery. Okay, so this is within 24 hours after delivery. Okay, so that is the reason while discussing the magnesium sulfate duration, we have studied a last onset of, we will continue for the 24 hours after the last onset of the seizure, or we will continue 24 hours after the delivery. Okay, so that is the reason why I told. So there is a chance of the postnatal eclampsia is also there, so which will happen within 24 hours after delivery. So that is the reason. So magnesium sulfate will be given 24 hours after delivery also. Okay, so or the 24 hours after the onset of the last seizure. Okay, so this is the very important thing we have to keep in our mind, right? So here comes to the next question, and very best question for you all. Yes, fatapat do response to the question and mention your correct answer in the comment box. Yes, at which serum magnesium level is loss of deep tendon reflex will happen as the early sign of the toxicity. Option A 5 milliequivalent per liter. Option B more than 30 milliequivalent per liter. Option C 10 milliequivalent per liter. And option D is the more than 15 milliequivalent per liter. Beta, so what is the normal serum magnesium level in the drug? Okay, so normal therapeutic index of the MgSO4, normal therapeutic index of MgSO4 is, so that is the 4 to 7 milliequivalent per deciliter. If the magnesium sulfate injection in the blood, if it is belongs to this particular therapeutic range, so that will be a useful. Okay, so it will be a normal in use. Okay, if it is less than 4, no use. Okay, if it is more than 7, it will get toxicity. Okay, if in case if the MgSO4 which is going more than 10 milliequivalent, okay, option A, that is the normal value. Okay, this is the normal value which is not in toxic value. Okay, so then comes to the option C, that is the 10 milliequivalent or the more than 10 milliequivalent per liter. So this is the toxic value, and here the early sign. Okay, here the early sign of the MgSO4 toxicity, that is the absence of deep tendon reflex will be there. Okay, so here will be the absence of the deep tendon reflex will be there. Very, very important, just we have to keep in our mind. Then if the blood blood magnesium level which is going more than 15 milliequivalent per liter, so in this particular situation there is a chance of respiratory depression will be there. Okay, chance of respiratory depression. And if the magnesium which is going more than 30 milliequivalent per liter, okay, so there is a chance of cardiac arrest. Okay, so there is a chance of cardiac arrest. Very, very important, keep in our mind, beta. So here the correct answer goes to the option C, that is the, okay, so when we will get the absence of the deep tendon reflex, so absence of the deep tendon reflex we will get during the, if the blood magnesium level is going more than 10 milliequivalent per liter, that time that is the absence of the deep tendon reflex will be there. And if the blood magnesium going which is more than 15 milliequivalent per liter, respiratory depression will happen. And if it is going more than 30, so there is a chance of the cardiac arrest will be there. Okay, so hope it is clear to every one of you. And here is the assignment. Here is the assignment. Okay, so just mention antidote for MgSO4 toxicity. Okay, so very, very important thing for you all, and very important question for you all. Okay, so just at the end of the video, okay, try to mention this one in the comment box. What is the antidote for the magnesium sulfate toxicity? Right. So hope that today's session is helpful for you all, and thank you for watching the video till the end. And once again, I am remembering, whoever preparing for the Norcet 9, we have the beautiful test series for you all, and here we are giving the real-time practice along with the time limit. Okay, so that is the Super 60 Norcet 9 and Norcet 9 Navagraha, where we are giving the very important classes along with that a test series also. And if you are preparing for the Norcet 9 and Norcet 10 full theory classes subject wise you want, means master batch we have. Okay, and if you are preparing for the RM series, means SGPG and KGMU, so we are having the test series plus the non-nursing classes. Okay, so that is very easily everything is explained to you all. Okay, in the RM series also. So if you want, so you can join the courses. Thank you so much for watching the video till the end, and take care of yourself. And I told the motivational line, don't stop. Okay, when you are tired, just take a rest when you are tired, and stop when you have done that one, and when you are satisfied about the particular work. Okay, so never ever you can land into the negativity. So try to spread the positive vibes, so that will be helpful for you also and your surrounding also. Thank you so much for watching the video till the end. Okay, stay connected, stay motivated, and stay positive, and keep preparing. Thank you, bye bye, take care, love you all. And don't forget to mention the special assignment question what I have given in the video. Okay, so just try to mention your answer in the comment box. Thank you so much, all the best.